Okay. So I'll share a story first. I'm a storyteller, and I do like to tell stories. So last November, I gave a talk, a keynote address for the Mexican Psychiatric Association. So I knew that I was given the talk maybe about 10 months before. And so I got Duolingo. And I practiced, and I learned Spanish. And so when I got to my keynote address, I was able to at least say my hello and my introductory part of my presentation in Spanish. So I thought, I'm going to do the same thing in Dutch. I will tell you that I failed. It was an epic fail. And so all I'm able to say here is, goedemiddag. Okay, so first I want to express my thanks and appreciation to the organizers for the opportunity to present the work of the Future DSM Strategic Committee. And it's led by Dr. Maria Oquendo, who is the chair of psychiatry at the University of Pennsylvania School of Medicine. She's the chair. We have Dr. Jonathan Alpert, who came with me here today, and he is the vice chair, and he's the chair of psychiatry at Albert Einstein School of Medicine. And Nitin Gote, who is the VP of Research at the APA, he's the other vice chair. And I serve on this committee as the senior advisor. So, before I get started, I really want to acknowledge that I am an employee of the APA, and my office oversees the DSM. So you can think about that in terms of any kind of conflicts, but otherwise I have no other financial conflicts of interest. So then also one of the things, to make the session a bit interactive, I've incorporated a few quick polls throughout the presentation. So when I get there, as you did this morning earlier, you'll just use your phone, scan the code, and respond to those questions. But I also want to make sure that I acknowledge that this presentation really serves as a summary of the work of our group over the past 16 months in our efforts to help the DSM advance with improvements in knowledge to become a more adaptable classification system, if you will, that will take a more holistic view of the person presenting for care. But this is the work of a group of people who have actually spent, over 1,700 hours just volunteering. These are people meeting every week for some of them, for the leadership group, twice a week for the leadership group actually, and then every 2 weeks, and for some groups monthly. And so that was when, early March, it was 1,777 hours. And so I really want to say this is not just me, it's a whole team of people working together. So here's one of the questions I'd like you to actually answer for me before we get into the presentation. I'm going to give a few. Okay. If I do this, I'll see better. Is it working? Yep, there we go. Really? Really? 8 people? Can I see the 8 people? I'm sorry. But, this is fantastic. So, part of what we're doing is we ask these questions and we take in that information and incorporate it in the changes and stuff that we do. So, just because of time constraint, I'm going to move on to the next one. And so the next question is this. So, what are some criticisms or concerns that you have regarding the current DSM? Okay, see the stigma, overlap, too rigid, labeling. Oh, people like this question. They're coming in faster. Or did I guilt you into responding? All right, again, I'm going to just move on. So, as we were thinking about the DSM, as we started this process, we knew that we had to think about what are the criticism in the field. We need to take a critical eye at the DSM. We want to look at some of its strengths, what are the strengths of the DSM and what are the weaknesses, and how do we address the weaknesses without any unintended consequences of it losing the strength that it has, right? And so, I'm going to talk a little bit about some of the strengths of the DSM. It has weaknesses, that is true. But the DSM provides a common language that has aided communication across different disciplines over the years, right? Decades. It allowed for some consistency in diagnoses. It provides criteria and description of mental health. Not perfect, but it did. Provide a standardized operational way of categorizing observable symptoms and behaviors, right? So clinicians can talk to each other, etc. It has emphasized culture. If you look through and go back through the DSM, there's always an emphasis on culture. Not as strong as we probably wanted it, but it did. It includes cultural idioms of distress, so clinicians can understand when some patients are presenting some symptoms. But as of the DSM-5, it incorporated the cultural formulation interview, which actually has been tested across the globe. And in addition, in the book, it also included across every diagnostic category a description of culture and cultural factors and things that we need to think about. Dear to my heart, as president of the International Academy of Suicide Research, we emphasize that suicide assessment and prevention matters, and it matters across diagnoses, not just for depression and substance use. And understand that some symptoms are transdiagnostic and that dimensionality matters. So for example, during the DSM-5 process, we developed the review of mental system, which was the DSM-5 cross-cutting measure. It didn't get as much uptake that we thought it would, and we take responsibility for that because I don't think we did as much education as we needed to do, and that's part of the reason as we're doing what we're doing now, we've created a education and dissemination subcommittee that's thinking of all the things that we need to get out to the field. It also has severity specifiers. We created a system. We realized that DSM need to have ongoing updates to inform quality care. And so we created an online system that we were hoping to have a living document. Technology wasn't at where we needed it to be at the time, and so it doesn't work as well as we want to, but it's a system that the field can propose changes to the DSM. And one of the things that we have actually done is to do this crosswalk between the DSM and ICD, and this is done for billing purposes. So it does have some strengths. Now, some of the weaknesses of the DSM or criticism is that it's atheoretical, right? But understanding the underlying genetics and neurophysiology of mental disorders is still in its developmental phase, right? And so, especially in earlier phases of the DSM, and so we understand that there needs to be this work, but there's still some work to be done in that area for it to be incorporated in the DSM. Another criticism is that it's categorical, right? But even though those symptoms are dimensional, we know that as clinicians, we still have to make categorical decision making. We have to decide, does a patient have a diagnosis or not? Do we treat, do we not treat? What kind of treatment do we give, etc. So our decisions are categorical. And given the state of the science, how do we figure out these cut points if we go on a dimensional scale? So we have to kind of think about that. Another criticism that we focus so much on reliability and validity is rather than validity, right? And so, but we don't know what the joints between diagnoses are yet. And so we know a lot more work needs to be done so we can understand the nature of the disorder itself and how do we identify those cut points even if we have a dimensional construct, and then we can actually assess validity more. Comorbidity is the rule. And this, again, is a consequence of the fact that the joints between diagnoses is not clear based on our current knowledge. Another criticism is neuroscientific measures such as biomarkers, genomics, etc. is not included in the DSM. But based on reviews and meeting with experts, and we've met with many of them, what we've identified is that these are not, we only have a few that are ready for a handful of diagnoses, but they're just not ready for prime time. Another criticism is that we tend to use expert consensus rather than empirically based evidence for the DSM. But absent of a clear definition of these clear boundaries between diagnoses, expert interpretation based on empirical data is the next best approach. So it's not that you sit in a room and make decisions. You have to review the literature. We do systematic review, and that's the information that informs the DSM. And I was part of the DSM-5, so I know that that's done. So the Future DSM Strategic Committee have taken all of this into consideration as we think through what do we need to do, and think about the criticism and the different things in the field, what went wrong with DSM-5, et cetera, and based on the evidence from the literature, created this model that we're proposing for the next iteration of the DSM. And so this proposed model, or the framework, will move diagnoses beyond symptom counts and a focus on the disorder or the label itself, so addressing that labeling thing that people mentioned. And the aim is that we try to get at what is going on with the person and why. So we've incorporated contextual factors, right? So a number of contextual factors. We've incorporated, figure out ways that we're going to incorporate biomarkers, transdiagnostic features to kind of address those comorbidity issues. And of course, we're going to retain the diagnoses. How they're retained is still under discussion. What this structure will be, and do we have a main category? So if a patient is being seen by a clinician, and a clinician is not 100% sure to begin with, they can use a broad category, and as they get to know the patient more, then they become more specific in the diagnosis that they provide to the patient. So I'm going to go again and do some quick polls, and I want to know, what do you do in your practice? Do you routinely assess or document, and I call them SCIDO, socioeconomic, cultural, and environmental determinants of health in your clinical evaluation of patients? Do you do that? So as soon as I hit about 600, I'll move on. Sometimes. Wow. All right, so 1% says not at all, but from a majority here, do incorporate it most of the times and for the rest some of the times. Keep your phone. Do you routinely assess and or document developmental or lifespan factors in your clinical evaluation of patients? And I'm going to move on to the next one. Do you routinely assess and document patients' level of functioning and or their quality of life in your clinical evaluation? I'm going to move on to the next question. And it is, do you routinely include information about biomarkers or biological factors when you're doing your evaluation? Okay. And so as you can see, I'm actually hitting all the domains here. And so my next question is, do you routinely document transdiagnostic dimensions in your clinical evaluation of patients? Fantastic. So what I'm going to do now is just talk about each of the domain, right? We know that context, and this is one of the criticism, context is marginalized in the current DSM. We know that social, cultural, and environmental factors are important, but yet they're often treated as secondary or optional, and it's poorly integrated in the diagnostic decision-making. And but what we're thinking about is that we need to incorporate these. So, these conditions are related to where the individual is born, where they grow, where they live, their age, and the systems that are in place to address their health. And all of these socioeconomic, I call it SCITO, so I'm going to stick with my SCITO. The SCITO factors are impacted by intersectionality, right? So a person of different age might have different access to things, even if they live in the same environment. Different gender, different class, etc., different sexuality. And we know that there's this interacting and bidirectional relationship between the SCITO factors and mental illness, and these are all shaped by intersectionality. And so our aim is to actually enhance how SCITOs and intersectionality are addressed in the DSM. So we want to move beyond just where we have it in the latter part of the book, where we provide Z codes, right? Other conditions that might be of interest. We want to move it up from there and make it an integral part of making a diagnosis of the patient. So it shouldn't be secondary. It shouldn't be a second thought, right? So we're moving it up. And so that's one of the things that we're actually working on, and we'll talk more about that. Development and lifespan factors, right? Development and lifespan factors determine how disorders emerge, how they're expressed, and how they should be interpreted over time, right? So if we think about age-specific phenotype, the same underlying construct can look very different across different ages, right? So you have to have this developmental approach when you're doing your assessment. Symptoms and behavior can be developmentally typical at one age or stage of development and be pathological at another. So taking that developmental approach will allow you to differentiate between pathology and normative development. We know that disorders are dynamic trajectories and not static, and so taking that developmental pathways approach is important. We know that at different stages of development, an individual can be at heightened vulnerability for certain disorder, certain conditions, and certain conditions have certain risk associated with it. And so that needs to be taken into account. So we know that as we're moving forward with the DSM, this needs to be very, very important, incorporated into the DSM and the contextual factor component, because having a system that integrates this can actually reduce risk of misclassification of normal variations in behaviors. It can reduce the risk of overlooking risk trajectories, and it can enhance the delivery of optimal care. Another area that's dear to my heart, I always found, anyway, impairment in functioning and quality of life. We know that impairment in functioning and quality of life, research studies have shown it, are factors that bring people to care, right? And it has been an important part of the DSM for many, many years, from DSM-3, right? With the inclusion of the clinical significance criterion, as well as the global assessment of functioning. However, during the DSM-5 process, based on feedback from the field, that the GAF was confounding. Sometimes when a patient comes for care, for them to be hospitalized, the GAF score was given for a certain number just to get them in. And then once it was time for them to be discharged, whether it's a day later, 2 weeks later, a month later, suddenly the score miraculously changed and got better. So that was something that was, that there was this idea that it was being misused. And so during the DSM-5 process, it was, how do we address this? So maybe we remove the clinical significance criterion and let the symptoms stay by itself, then we have an independent assessment of functioning, and then between those two combined together, you create a case. In doing this, we decided that we'd use the HUDAS. We tested it and put it in section 3 of the DSM, and that this would be along with the diagnostic criteria, here would be the symptoms, the assessment of functioning, and then those two would work. But the HUDAS got placed in Section 3, and it inadvertently sent the message that functioning was no longer important. And so the aim of this, the work we're doing right now is to do this refocusing on functioning. Then when we think about quality of life, studies have shown since the 1970s that quality of life is an important outcome for health and mental health. And yet it's only sparingly used in a mention in the DSM. Yet we know, based on the literature, for some individuals, for some groups, it doesn't matter that they have symptoms of depression. They get up, they go to work, they have to function. But when you do talk to them, they will let you know that their quality of life is not good at all. And so incorporating and thinking about culture would be, quality of life might be important for some cultural group more so than others. But incorporating it is important. But what we're grappling with right now is, should this be a focus of the psychiatric diagnosis? Should this be included in the clinical significance criterion? So clinical significance criterion becomes experiencing clinical distress, impairment in functioning, or impairment in quality of life. Is that something that we do? And then also, when do we incorporate it in there, or is it just simply a contextual factor? So that's something that we're still working on. Lots of work still to be done in that area. Biomarkers. So we know that psychiatric disorders is an interplay between environmental, socioeconomic, cultural, psychological, developmental, biological factors. And since the DSM, DSM-3, we've mostly focused on observable characteristics, just the phenotype, rather than the underlying mechanism. And the advances in neuroscience, as we have mentioned before, have yielded some insight into that are related to psychiatric diagnoses, but the evidence is not always strong. So for example, we know there's strong evidence that supports that biological factors matter in psychiatric diagnoses or psychiatric disorders. We have moderate evidence regarding stratification markers in selected contexts. But when it comes to identifying routine clinical biomarkers, the evidence is weaker, especially biomarkers that can diagnose different disorders. So the key goal of the Future DSM group is to include emerging candidate biomarkers and biological factors as they get validated. And when we talk about validation, we're talking not just a single replication in the same lab, but we're talking about independent replication, independent cohort, independent laboratories. So what's the current state of the evidence? As I said, the best supported biological themes are around polygenic risk factors, shared neurodevelopmental and circuit level mechanisms, and immune metabolic alteration. And these come from some large-scale studies. As I said, candidate biomarkers still have not met the level of evidence for them to, for us to say that they've been externally validated and that they're generalizable across all disorders in order for it to be incorporated in psychiatric nosology. So our goal is to, as we're working through and identifying biomarkers and biological factors, we're hoping that we're able to do that to inform the field about promising areas of work that's poised to inform diagnosis and treatment of mental disorders, and then also to develop a rigorous, standardized, evidence-based framework for determining which biomarkers are sufficiently validated and so can therefore be included in the DSM. And so what we've done right now is we've created a repository, We've created a repository, and we call it a survey, and this link can get you there, that if you are in the field and you're doing biomarker research, you can go to that link and propose a biomarker to be incorporated into the DSM, but of course it needs to meet strong evidence, and the criteria are, or at least the evidence that you need to provide is listed in the first part of the repository. So we know that we have transdiagnostic dimensions, so we know these are symptoms or core psychological, behavioral, or biological processes that spans across disorder. As I mentioned, DSM-5 tried to address this by creating the DSM-5 cross-cutting measure, which is 13 domains that were considered, a review of mental system. They cut across diagnoses. They represent shared mechanisms. They represent factors that can emerge before full disorders, a full condition get diagnosed, or a disorder condition become full-blown disorder, and can enable prevention, right? It also can explain and help with thinking about treatment and thinking about prognosis for the patient, and can help explain comorbidity. So we're trying to figure out, how do we incorporate those in the DSM? Do we create a system similar to what we're doing with the biomarkers? That we haven't come to the final conclusion about, but that's something that we're working on. So what I want to do now is just kind of walk through some clinical scenarios, but focusing on contextual factors, especially since I have 9 minutes to go. So here's the model, right? And we're going to focus on the contextual factors, so we'll focus on the social, economic, cultural, and environmental determinants of health. So a patient with depressed mood presents for a clinical evaluation. The intake form indicates that the patient hears voices and holds unusual beliefs. How is this best understood? As a symptom of psychopathology or a cultural normative experience? What would you say? Okay. I don't know. Okay. Okay. So it's not clear, right? So here. Upon probing further, you learn that the patient hears his grandmother's voice speaking to him, and his unusual belief is that he can communicate with her and other dead loved ones. Then you also learn that his culture holds the normative belief that the spirit of your loved ones who have passed on can guide and protect you, right? Would this cultural background information shift your diagnostic decision? Oh. Okay. A few people have said no, they're going to stay with what they have, okay. Okay, as we're thinking through this, we know that taking a cultural lens, we know it doesn't mean that the person doesn't have the diagnosis of, say, for example, if you're thinking a psychotic disorder. But what it does is that it can allow the clinician to think broadly and to understand the patient better, right? So paying attention to the patient's cultural background, spiritual framework, etc., is important because it can help you distinguish culturally congruent experiences, and it can inform diagnosis and interpretation of symptom severity and reduce the risk of mislabeling or over-pathologizing the presentation, right? And provide some clarity of context that can inform person-centered care. There are other socioeconomic, sociocultural, and schizo factors that may be important. So further probing revealed that the patient was laid off from his job almost a year ago and has no luck finding employment. He is the main breadwinner in his family of 4. His unemployment is about to run out, and he recently received an eviction notice. So just kind of think about how this information, and how useful this might be in diagnostic formulation. So documentation of such factor provides critical context for what the patient is presenting, right? And taking into consideration these factors can help highlight potential barriers to treatment and potentially what sources of treatment you might need for this patient, maybe connecting them to social worker, et cetera. So different things that you can actually do. So it informs your next step. So I'm going to move on to developmental factors. An individual presents for an initial clinical evaluation with irritability, anxiety, lack of interest in things, sleep disturbance, and concentration problems, right? So I can see thinking about anxiety, thinking about depression, right? But think about how your interpretation of these symptoms would change if you're dealing with a patient who is 8 years old, right? Versus if you are dealing with a patient who is a 8-year-old woman who is 3 months postpartum. Or you're dealing with a patient that's 70-year-old, he's a 70-year-old man with a history of hypertension, cardiovascular disease, chronic pain. A developmental lens is important because it allows you, the same symptoms can have different meaning depending on the age of the individual as well as other contextual factors. And so this developmental lens should be applied regardless of age because the diagnosis can reflect different things, and we know that symptoms are not static. Moving on to quality of life and functioning. So 2 individuals meet the criteria for the same DSM diagnosis with comparable symptom severity. Yet they differ in both functioning and quality of life in clinically meaningful ways, right? So you can see person 1 reports a strong sense of self, sense of meaning and satisfaction with daily life and relationship. So they have positive quality of life, yet they struggle in specific areas of role demands, self-care, and occupational functioning. I think of one of the first patients I had, and she just kept saying, I don't understand why I'm depressed. Everything in my life is good. I have a great husband. I have a nice home. I have all these things, and yet I'm depressed. So that's what you're seeing here. Patient 2 meets the expected role obligation and appears outwardly high functioning, yet experiences low quality of life characterized by social disconnectedness, diminished pleasure, and a sense of purposelessness. So assessing both the functioning and the quality of life draws on multiple perspectives, including you can get it from the patient, the family, clinician where feasible, and it can help clarify the patient's illness burden, and it can also guide the focus of treatment, support shared decision-making, etc., and lead to a more individualized care within the same DSM category. So those are things that we're thinking about and why we know that incorporating and refocusing on functioning and also bringing in quality of life becomes important. And you've seen in the news, hope you have, where you have a number of individuals, African Americans, some cultural group, more so than others, who are classified as high functioning and having high functioning depressed individual and dying by suicide. So important for us to actually assess more than just how are they functioning, the symptoms that they're experiencing. So to wrap up, in summary, the model that we're thinking about, what we're hoping in terms of its clinical implication in that it will enhance clinical judgment, provide a more comprehensive diagnostic formulation. It can support precision psychiatry, so if you're looking at different things that impact the person rather than just looking at the label, you can do more personalized planning. It can inform and improve longitudinal care, facilitate interdisciplinary communication through having this common language and common things to look at, reduce diagnostic reification by encouraging exploration and longitudinal documentation, and reduce stigma, which we all talk about as being one of the weaknesses of this DSM, by taking this holistic approach to the patient's diagnosis. When it comes to research, what this does is enable dimensional and hybrid models for research. It can improve phenotypic precision and reproducibility because we have this clear model. Because we are now planning to have more of a living document framework, if you will, it's going to allow for incorporating emergent evidence in psychiatric nosology. And because we've had advances in technology, AI, this living document framework is more possible compared to when we thought about doing it in 2013. And so we can move towards precision psychiatry for research as we develop more and try to develop more biomarkers, digital phenotyping, etc. So in closing, I have one more question for you, and it's this. Do you think the model that we've now proposed or this diagnostic formulation for the future will be useful in your practice or disruptive? What do you think? So I know I was told, stick to my time, so I want to say, dank u wel. Did I say that right too? Thank you.